Hello and welcome to this session. My name is Stephen Davis, I'm the registered nurse, and I'm going to run through consent and mental capacity with you. So let's just look at what consent is. So consent is the ability for us to choose what it is we want to have done. It may be choosing where we eat, what we wear, or even what treatment we're going to receive from people. Therefore, it's vital we gain consent from people for every single task on every single occasion, because we're entitled to change our minds. For consent to be valid, we must ensure that the person has had a significant amount of information to weigh up the decision that's being said. It needs to be valid. The information needs to be given freely and without pressure. There shouldn't be any influencing. We need to ensure that the person has the capacity to weigh it up, and we'll talk about capacity later. They may have questions and that people may need to answer, and they may do this in a way where they don't feel persuaded by relatives or carers. So an example of consent would be, would you like to get up this morning, yes or no? And we would need to give them the information freely. So they may say no, and they may be in a bed that's full of incontinence or soiled. So it's important that we explain to them, if you lay in this, you may end up with pressure sores, you may end up with moisture lesions, and again, you could be cold, and it may be an hour or so before I'm able to come back to you. So we've given them the information for them to weigh up the choice and risks, for them to come to a conclusion on whether or not they want to be treated. Remember, people are entitled to make choices, even unwise ones. So where would we go to find this recorded? Well, it's important that we look at the care plan and think about the information that's been given to us. The care plan should be well documented and should have evidence around capacity and consent. The care planning cycle is done through a process where it's written, assessed, planned, implemented and constantly reviewed. Remember, consent has to be given about decisions on every occasion, because we can change our minds. But capacity is fluid, and things that can make our capacity come and go may be things such as ill health or stress or other situations. So when we revise the care plan, it's important we're looking at the person's ability. Are we taking into account their best interests? Do we look at the decision-making process and we review the capacity as it stands? It's important to follow the Mental Capacity Act when recording and planning these processes. We need to know how good practice takes into account, therefore it's important we read the Mental Capacity Code of Practice, we follow CQC guidelines, and we follow our own company policies and procedures. It's important for you as a caregiver to read the codes of practice to understand how they work along your everyday roles and responsibilities. It comes in a two-stage test. It's important that we work alongside the best interest checklist and apply these to interest decisions and make sure that they're recorded. They need to be integrated into the care plan. Code of practice look at the best practices of way working with consent and capacity. It's important that we record any decisions reached and how they got reached, or if we were unable to gain consent and why we were unable to gain consent. We need to work sometimes in the best interest of somebody, and again, that may be required with a collaborative or a multidisciplinary approach. CQC require us to ensure that the person is at the centre of the care plan, and you covered that in your care certificate, personal centre caring. Again, you can see around Regulation 9, it asks us to take into account people's capacities and ability to consent. Consent to sharing information, consent to treatment, and consent to being assessed. SCIE, the Social Care Institute of Excellence, also has come up with a mental capacity planning care plan. It breaks down all the principles and enables you to go through it in a more easy to understand manner. And it's important we have it in an easy to understand way for our customers and people to understand as well. Care and support plans should consider questions around autonomy and liberty. They reflect the efforts that staff have had to make to maximise people's capacity to be involved in the decisions that they're in. It's important we reflect on the rights of people who have capacity, even to make unwise ones. Good practice is about where you can use the test, you should record it as evidence. If you decide not to follow something the person's put in writing, you must record the reasons why. It's also good practice for healthcare and social care staff to record that at the end of the process and why they think specific decisions for the person's capacity or best interest has been reached. Staff involved in the care of a person who lacks capacity should make sure a record is kept of the process of working out how the best interest got reached. Each relevant decision setting out how the decision of the person with the best interest was reached, what the reasons were for reaching those decisions, who was consulted, and what particular factors were taken into account. The record should remain on the person's file and be contributed towards the person-centred care plans. Mental capacity ensures that we assume people have capacity unless otherwise stated. It's important that we maintain that as one of the key fundamental principles, and we'll talk about that shortly. This will then always allow the staff to carry out their actions in a way that plans and reasonable belief that the person who lacks capacity and their actions are in the person's best interest. Care plans are written in the first person. For example, I like to have a bath every morning and I have to have my hair washed. It's important we write this because it shows that they've been involved in the decision-making process. Examples. A person with capacity has the right to make their own decisions about having their hair washed, how often and with what products. The care plan could be written in the first person and have their signature. A person who lacks capacity should have a care plan that demonstrates the two-stage test that's been used in the best interest checklist. Their family may sign to say that they have been consulted, and the care plan will be in a third person, so acts of care like hair washing. This can be carried out by care workers under reasonable belief that a lack of capacity and the care outlined is in their best interest. So for example, on the left-hand side, you may see, I would like my hair washed once a week. On the right-hand side, you may see the customer needs their hair washed once a week. So we have it in the first person and in the third person. So let's look at this in a little bit more detail. The Mental Capacity Act has 5 principles, and it's important we understand all 5 principles. At the heart of the Mental Capacity Act, it looks at the concept and has the statutory principles considered. These are benchmarks. They allow us to move freely and to apply it fairly and equitably across the assessment. Principle 1 assumes that everyone has capacity. Every adult has the right to make his or her decisions and must assume that they have the capacity to do so unless otherwise stated. This means you cannot assume that someone cannot make a decision, therefore just because they have particular medical conditions or disabilities. Principle 2 looks at individuals being supported to make their decisions. A person must be given the help before anyone is treated not to be able to make their own decisions. This means we should make every effort to encourage people to have the right support to make the decisions for themselves. If they lack the capacity, it is still important that we involve the person as far as reasonably possible in the decision-making process. Unwise decisions So people have the right for unwise decisions. People have the right to make and regard an unwise decision. Everyone has their own values, their own beliefs and their own preferences, which may not be the same as others. Therefore, you cannot say somebody lacks capacity just because of this reason. Principle 4 looks at best interest. If a person has been assessed of lacking capacity, then the actions we take and the decisions we take must be in the person's best interest. Principle 5 looks at the least restrictive option. Therefore, somebody who is making a decision on behalf of somebody else who lacks capacity must consider whether or not the decision acts in a way which would interfere the least. This ensures the person's rights and freedoms are acted upon. It's important that we have minimum restrictions and is essential to all parts of the care and under all circumstances. So let's just look at some of the things what we would need to consider when assessing capacity. Considering the following factors when assessing individual capacity to make a decision. We assume somebody has the capacity. We understand what is meant by capacity or the lack of capacity. We would treat everyone equally. We support the person to make the decisions to themselves, and what is mental capacity and what might be assessed as capacity. So when we're assessing capacity, we follow the 5 principles. What we're assuring is that when somebody is making a decision, we're providing them the information in a way that can be understood. We must be able to explain the situation, and they must be able to hold that. They must be able to weigh up the information which we've given and retain it. And they must be able to come back and talk about what it is that they've said. It's important, just because somebody may have a disturbance of the mind or a temporary lack of capacity doesn't mean it holds forever. However, we may end up in situations after doing a mental capacity assessment that the person clearly is unable to weigh up risk and is unable to weigh up choice. If that's the case, we move down to the next phase where we may implement the Doles Act. So the Doles is a deprivation of liberty orders, and it basically means we're going to write to the local courts to get some kind of guidance and protection around that person to prevent them from being at harm or at the risk of being abused. The courts will weigh up the evidence and decisions, and they will either grant a Doles Act or not grant a Doles Act. It's important to say that that whole process is being reviewed this year in line with new legislation to make it a little bit more quicker and simpler. So the things that we need to consider when we're talking to our customers. One is to ensure people have the right to consent, that they're able to make choices freely, weighed upon the information that they've been given. 2, we assume that they have capacity unless stated otherwise. If they haven't got capacity, we'll work in their best interest and apply the least restricted options. If they do have capacity and they make unwise choices, we just need to be sure that we've provided the information for them around risk and that they've been able to weigh that up. If you're worried that at any time you're talking to somebody and you feel they lack capacity because they're not able to weigh up what you're saying, then by all means please talk to your supervisor or care managers. They will go out and conduct an assessment quickly. This ties in to the other sessions that you've done around person-centred care and safeguarding adults. It's a basic fundamental requirement to understand capacity and the Mental Capacity Act. I'd like to thank you for watching. If you have any other questions, by all means please escalate them up, and it's important you read your policies and procedures in line with your company's requirements. Thanks for watching.